The subject of our lecture is differential diagnosis of cardialgias. Differential diagnosis of the genesis of chest pain. There are two types of chest pain. Cardiogenic pain, pain associated with the heart disease. Non-cardiogenic chest pain associated with pathologies of organs and tissue other than the heart. What is the genesis of cardiogenic pain? There are two types of cardiogenic pain. Coronary pain. It occurs when there is a violation of blood circulation in the coronary arteries for various reasons: ischemic pain, central chest pain. The second is non-coronary pain, pain associated with cardiac pathology in the presence of intact coronary arteries, heart pain or cardialgias. Genesis of non-cardiac pain. There are four etiologies of non-cardiac chest pain: pathology of organs of mediastinum, pathology of the lung and bronchi, chest wall pathologies, abdominal pathologies, often occurs as a result of irradiation. Pathology of organ of mediastinum, such as pathologies of the ascending and thoracic aorta, aortitis, aortic dissection, etc. Esophageal pathologies, esophagitis, ulcers, achalasia. Pathologies of the trachea, tracheitis, pharynx body. Lymph node pathologies, lymphoma, lymphadenitis. Thymus pathologies like thymoma. Pathology of the lung and bronchi, such as pneumonia, bronchitis, pleurisy, pneumothorax, bronchiectasis, and tumors. Chest wall pathologies, such as pathology of the vertebra, osteochondritis of the neck and chest, myositis, neuralgias and neuritis, herpes zoster, injuries to the chest, bruises, rib fractures, diaphragmatic hernia of the esophagus, breast pathology in women. Abdominal pathologies, such as pathologies of the stomach like gastritis, ulcer, and so. Pathologies of the gallbladder and biliary tract, stones, inflammation, etc. Pancreatitis, rarely left-sided renal colic. These pains often occur as a result of irradiation. Other conditions with chest pain are psychological, other problems such as panic attack, anxiety disorders, cocaine abuse, severe anemia, sickle cell anemia, somatization. Disease accompanied by cardialgias as follows: myocarditis, endocarditis, acquired and congenital heart defects, cardiomyopathy, mitral valve prolapse, acute and chronic pericarditis, sometimes accompanied by central chest pain, cardiac myxoma, and coronary heart disease. Disease with chest pain that can kill. It is mean life-threatening condition. Those are acute coronary syndrome, pulmonary embolism, aortic dissection, esophageal rupture, pneumothorax, and pneumonia. Disease accompanied by central chest pain as follows: ischemic heart disease, stenosis of the aorta, coronaritis, idiopathic hypertrophic cardiomyopathy, dissection of the ascending aorta and thoracic aorta are also accompanied by central chest pain. Differential diagnosis of chest pain. Pain due to cardiovascular disease, angina pectoris, processes is temporary myocardial ischemia, usually secondary to coronary atherosclerosis. Location at retrosternal or across the anterior chest, sometimes radiating to the shoulder, arm, neck, lower jaw, or upper abdomen. Quality like pressing, squeezing, tight, heavy, occasionally burning. Severity is mild to moderate, sometimes perceived as discomfort rather than pain. Timing is usually 1 to 3 minutes, but up to 10 minutes. Prolonged episodes up to 20 minutes. Factors that aggravate are exertion, especially in the cold, meals, emotional stress may occur at rest. Factors that relieve are rest, nitroglycerin. Associated symptoms are sometimes dyspnea, nausea, sweating. Myocardial infarction process is prolonged myocardial ischemia resulting in irreversible muscle damage or necrosis. Location is same as in angina. Quality is same as in angina. Severity is often, but not always, severe pain. Timing is 20 minutes to several hours. Associated symptoms are dyspnea, nausea, vomiting, sweating, weakness. Pericarditis process is irritation of parietal pleura adjacent to the pericardium. Location is retrosternal or left precordial, may radiate to the tip of the left shoulder. Quality is sharp, knife-like. Severity is often severe. Timing is persistent. Factors that aggravate are pressing, changing position, coughing, lying down, sometimes swallowing. Factor that relieve is sitting forward. This may relieve it. Associated symptoms are seen in autoimmune disorders, post-myocardial infection, viral infection, chest irradiation. Dissecting aortic aneurysma process, a splitting with the layers of the aortic wall, allowing passage of the blood to dissect a channel. Location is anterior chest, radiating to the neck, back, or abdomen. Quality is ripping, tearing. Severity is very severe. Timing is abrupt onset, early peak, persistent for an hour or more. Factors that aggravate is hypertension. Associated symptoms are thoracic hoarseness, dysphagia, also syncope, hemiplegia, paraplegia. Pain due to respiratory pathology of respiratory organs. Tracheobronchitis process is irritation of trachea and large bronchi. Location is upper sternal or on the either side of the sternum. Quality is burning. Severity is mild to moderate. Timing is variable. Factors that aggravate is coughing. Factors that relieve lying on the involved side may relieve it. Associated symptom is cough. Pleuritic pain process is inflammation of the parietal pleura as in pleurisy, pneumonia, pulmonary infarction, or neoplasm. Location is chest wall, overlying the process. Quality like sharp, knife-like. Severity is often severe. Timing is persistent. Factors that aggravate it are deep inspiration, coughing, movement of the trunk. Associated symptoms are of the underlying disease. Pain due to gastrointestinal and other organs disease. Reflux esophagitis process is inflammation of the esophageal mucus by reflux or gastritis of gastric acid. Location is retrosternal, may radiate to the back. Quality is burning, maybe squeezing. Severity is mild to severe. Timing is variable. Factors that aggravate are large meal, bending over, lying down. Factors that relieve are antacids, sometimes belching. Accompanied symptoms are sometimes regurgitation, dysphagia. Diffuse esophageal spasm process is motor dysfunction of the esophageal muscle. Location is retrosternal, may radiate to back, arm, and jaw. Quality is usually squeezing. Severity is mild to severe. Timing is variable. Factors that aggravate are swallowing of food or cold liquid, emotional stress. Factors that relieve are sometimes nitroglycerin. Associated symptoms is dysphagia. Chest wall pain, costochondritis. Process is variable, often unclear. Location is often below the left breast or along the costal cartilage. Quality is stabbing, sticking, or dull. Aging. Severity is variable. Timing is fleeting to hours or days. Factors that aggravate are movement of chest, trunk, arm. Associated symptom is often local tenderness. Anxiety. Process is unclear. Location is precordial, below the left breast or across the anterior chest. Quality is stabbing, sticking, or dull aging. Severity is variable. Timing is fleeting to hours or days. Factors that aggravate are may follow effort, emotional stress. Associated symptom is breathlessness, palpitation, weakness, and anxiety. First, we should detect, is the pain cardiogenic or not? Treat patient as thought he is critical until proved otherwise. History. Risk factors. History of ischemic heart disease. Previous medicines. Previous chest pain. Pain, heartburn, burning sensation, chest pain with pressure, tightness. Remember, treat with cause. There are many causes. Occurrence of chest pain. Diagnosis using the history and physical examination. Determining whether pain is substernal, provoked by exertion, relieved by rest, or nitroglycerin. Helps to clarify whether it is typical anginal pain, has all three characteristics. Atypical anginal pain has two characteristics. Non-anginal pain has only one characteristic. Again, we will repeat common cause of chest pain: aortic pain, aortic dissection, aortic aneurysma, esophageal gastrointestinal, esophagitis, esophageal spasm, esophageal tear, pancreatitis, biliary gallbladder disease, gastroesophageal reflux disease, peptic ulcer, lungs and pleura, bronchospasm, pulmonary embolism, pneumonia, tuberculosis, tracheitis, pleuritis, pneumothorax, malignancy, and asthma. Musculoskeletal, osteoarthritis, rib fracture, costal muscle injury, costochondritis, cervical disc disease. Neurological, prolapse disc, herpes zoster, thoracic outlet syndrome. Psychologicals and others, panic attack, anxiety disorder, and cocaine use. Cause of sudden and spontaneous pain in the chest are pulmonary embolism due to deep vein thrombosis, obesity, pregnancy, prolonged immobilization, cardiac heart failure, tension pneumothorax, spontaneous and open pneumothorax. This is the chest X-ray of the patient with pneumothorax. In the right, patient with tension pneumothorax. Diagnosis of pneumothorax: sharp chest pain, dyspnea, absence of breath sound in the affected site. Radionuclide studies graded 2. SPECT single proton emission, computed tomography, PET position and emission tomography. Pulmonary embolism, sudden pleuritic substernal pain with dyspnea, tachycardia, fever or cough, diaphoresis, mimic myocardial infarction, and angina. Diagnosis due to ventilation perfusion scan, the dimers, and spiral CT scan, best diagnostic tests. Pneumonia, infection of pulms, pulmonary infection, tissue, interstitial space, alveoli, and bronchioles. Chest pain, pleuritic, something suddenly. Febrile, chills, cough with copious blood-stained sputum. Rales, rhonchi, wheezes, hypoxia. Substernal epigastric chest pain, intensified with swallowing. It is like chest malignancy, you can see here. In this slide, you can see herpes zoster. This is the rashes of herpes zoster also accompanied by chest pain. Chest pain due to gastrointestinal disease, pancreatitis, pain in the left upper quadrant, substernal, radiated to back, difficulty in breathing, tachycardia, vomiting, worse in supine, better while leaning forward. Cholecystitis, pain in right upper quadrant, precipitated by meal. Gastric ulcer, pain left epigastrium, radiation to back. Duodenal ulcer, mid-epigastric pain, cramping, 2 to 4 hours after meal. Esophageal rupture, Mallory Weiss syndrome, sudden severe chest pain following by vomiting, or upper gastrointestinal tract procedure. Early chest X-ray shows mediastinal or free peritoneal air. Hours to days later, widening of mediastinum, pleural effusion. Cardiac chest pain. It is like a descending aortic aneurysm, cardiac tamponade, heart failure, periendomyocarditis, cardiogenic shock, mitral valve prolapse, mitral stenosis, acute coronary syndrome like myocardial ischemia, stable angina, unstable angina, myocardial infarction, and pericarditis. Thoracic aortic dissection of aneurysma. Blood violates aortic intima and advential layers. False lumen is created. Dissection may extend proximally, distally, or in both directions. In this slide you can see symptoms of thoracic aortic dissection. Constant on powering chest pain, deep diffuse in supine position, cough, dyspnea, stridor, aphonia, loss of voice. Now we will talk about coronary artery disease. You can see coronary artery branches in this slide. This left main coronary artery, left circumflex artery, and right coronary artery. This is the main coronary arteries. In this slide, you can see plaque inside the artery. This is coronary artery atherosclerosis. Heart disease begins when cholesterol, fatty material, and calcium deposit in the arteries. It is called atherosclerosis. You can see this blood clot resulting in the myocardial damage, dying myocardium. This is a healthy muscle. This is a healthy coronary artery, but there is thrombosis. And can you see also cholesterol plaques inside the artery. In this slide you can see places of pain during ischemic chest pain. This is like myocardial ischemia, expected companion of ischemic heart disease. Pain up to the neck, jaw, and cheeks. Right shoulder, below ribs. Left shoulder, under breast, bone, and down arm. This is a patient with rest of the patient with chest pain. It is calling living sign. Clinical symptoms of stable angina. You can see in this slide. Symptoms: chest discomfort, heaviness, pressure, squeezing. Living sign: crescendo decrescendo for 2 to 5 minutes. Radiation of pain, mostly exertional or unpredictable. Relief on stopping all nitroglycerin. Anginal equivalence. It is a pressure in the chest, spreading pain, lightheadedness, sweating, or nausea. Stable angina. Signs: asymptomatic between episodes. Sign of the positive risk factors. Palpation, akinetic or dyskinetic apical beat. Auscultation, the risk can be murmur. Clinical symptoms of unstable angina. Symptoms: chest pain, severe, longer at rest. Anxiety, fear of impending down, diaphoresis, breathlessness, collapse or syncope, nausea, and vomiting. In this slide you can see characteristic heart attack sign in women. Pain or discomfort in one or both arms, the back, neck, jaw of stomach or stomach. Shortness of breath with or without chest discomfort. Breaking out in a cold sweat, nausea, or lightheadedness. As with men, women's most common heart attack symptoms is chest pain or chest discomfort. Other common symptoms, particularly shortness of breath, nausea, vomiting, and back or jaw pain. On this slide you can see type of angina. Angina, it is a myocardial ischemia. Stable angina, exertional angina. Stable pattern of onset, relieved by rest and sublingual nitroglycerin. Unstable angina. Peri-infarction angina. Unpredictable, not relieved by nitroglycerin. Variant angina is calling princemetal vasospastic angina, without relation to effort, occur at rest between midnight or early morning. The risk can be elevation. Intractable angina, chronic, incapacitating, unresponsive to treatment. Pre-infarction angina lasts more than 15 minutes. Post-infarction angina, that myocardial infarction or residual ischemia. Now I will introduce to your kind attention classification of ischemic heart disease. First is sudden death. The second is angina. Stable angina, there is 4 functional classes or stable angina functional classes. First, second, third, and fourth functional classes. Unstable angina include angina pectoris de novo, spontaneous angina like principal angina or variant angina, angina after myocardial infarction, angina pectoris after percutaneous coronary intervention or coronary artery bypass grafting, progressive stable angina, angina at rest. The third is myocardial infarction. It can be without Q waves or with Q waves. Post-infarction cardiosclerosis. The fifth is heart failure, arrhythmia and blockage, and X syndrome. Coronary heart disease is sometimes atypical or painless, such as in diabetes mellitus. What is the acute coronary syndrome? This includes unstable angina, this angina pectoris, pain lasting more than 20 minutes, first onset of angina pectoris, progressive angina, myocardial infarction without ST elevation, and myocardial infection with ST elevation. Acute coronary syndrome, you can see unstable angina, there is rupture of the plaque, ST elevation, myocardial infarction, there is thromb, which one is closed or blood was inside the vessel, and no ST elevation myocardial infarction. There is some way inside the vessel, otherwise is thromb inside of vessel coronary artery. ECG diagnosis of myocardial infarction. Now we will talk about ECG changes. In the first, we should see which kind of surface of the left ventricle: inferior, underneath, anterior, front, lateral left side, and posterior back surface of the left ventricle. ECG diagnosis of heart disease. There is 2 types of leads: limb leads, this first, second, and third standard leads, and augmented leads, right, left, and foot leads, and chest leads. This is the V1, V2, V3, V4, V5, and V6 chest leads. Limb leads. There is 3 bipolar leads from Eindhoven triangle. Leads 1 is measures electrical potential between right arm and left arm. Lead 2 measures electrical potential between right arm and left leg. And lead 3 measure electrical potential between left arm and left leg. Augmented limb leads. There is 3 unipolar leads: AVR right arm, AVL left arm, and AVF left foot. Note that right foot is a ground lead. This is chest leads. They are unipolar leads: V1, V2, V3, V4, V5, and V6. Left posterior chest leads: V7, V8, and V9. Right chest leads: VR1, VR2, VR3, VR4, VR5, and VR6 chest leads. Now we will talk about damage of the heart valves: left ventricle, posterior, inferior wall, and their leads. The damage we can see in the second, third, and AVF leads. This area supplied with right coronary artery. Inferior leads, you can see second, third, and AVF. This inferior wall of the left ventricle and the leads, which one shows the damage of this site, is the second, third leads, and AVF leads. You can see in this slide is the elevation on second, third, and AVF leads, and is the depression on leads AVL and first lead. Is the elevation and is the depression in the AVL and first lead. Also on V1 and V2 leads, you can see these reciprocal changes in the anterior wall. Reciprocal changes like ST depression is the calling reciprocal changes. On this slide you can see the elevation on the second, in the third, and AVF leads, and reciprocal ST depression in the first, in the AVL, and V1, V2, V3 leads. Also, you can see on this slide the elevation in the second, third AVF leads, and reciprocal ST depression in the first AVL and V1, V2, V3 leads. It is the reciprocal changes. This is also the elevation in the V3, V2, V3, AVF, and reciprocal ST depression in AVL and V1, V2. This is opposite leads changes. Anterior wall of the left ventricle. Anterior wall of the left ventricle and septum. This is this side. Damage in this side shown in V1, V3, and V4 leads. supplied with left anterior descending artery. You can see this anterior wall changes in V2, V3, and V4 leads. This is anterior wall myocardial infarction. You can see is the elevation in V1, V2, V3, V4 leads. Reciprocal changes will be in the posterior leads, V7 and V9. This is not shown. Also, you can see elevation in V1, V2, and V3 leads with anterior wall myocardial infarction. On this slide, you can see a elevation in V1, V2, V3, V4, V5, and V6 leads to the total myocardial infarction. It is anterior wall and left wall of myocardium. Left ventricular side valve is show V1, V5, V6, first and AVL leads, supplied with circumflex branch is the left valve. You can see ECG leads this left side of the myocardium, of the ventricle. It is V5 and V6 leads, and this left side in the first leads, and AVL leads can show changes in this valve. You can see the elevation on the first lead, AVL, and V5, V6 chest leads with a side lateral wall myocardial infarction. Reciprocal changes on the you can see on the third leads and AVF is the reciprocal change beside it. In this slide, you can see also as the elevation in first AVL and V5 and V6 leads, and reciprocal changes on the third is the depression you can see, and AVF also you can see is the depression in those leads. On this slide, you can see is the elevation on the first lead, the elevation in the first lead. In AVL, you can see is the elevation, and V5 and V6 leads, and reciprocal changes beside leads, you can see as the depression in the third and AVF leads. Anterolateral myocardial infarction. You can see is the elevation on the first AVL, V1 and V2, V3 leads, and reciprocal changes you can see in the third, as the depression in the third and AVF leads. This is the lateral walls like V4, V5, V6 also is the elevation. You can see the same changes in the slide like ST elevation in first AVL and from V1, V2, V3, V4, V6 and V5 and V6 leads. This is the anterolateral myocardial infarction, and the reciprocal changes like ST depression you can see in the third and AVF leads. This is the inferolateral myocardial infarction. There is changes like ST elevation in the second, like inferior wall, in the third and AVF, and V5 and V6 leads. Reciprocal changes you can see in V1 is the depression, and V2 like is the depression. Posterior basal wall of the left ventricle. Posterior basal infarction is very rare. In frontal leads, the infarcts appear as a mirror images of the changes. Normally, lower wall ischemic changes occur, supplied with right coronary artery. This is the side is basal wall of myocardial of the left ventricle. Posterior wall myocardial infarction often accompanies inferior or lateral myocardial infarction. Isolated posterior myocardial infarction is less common. Posterior extension of inferior or lateral myocardial infarction implies large infarct area, difficult to pick up on ECG. And you can see only reciprocal changes like in V1, V2. There is ST elevation in V7 and V8 or V9 leads. ECG findings changes in V1, V3. Horizontal is the depression, tall, broad air waves, upright T waves, dominant air waves. Ratio R to S is more than 1 in V2 leads. You can see the elevation on V7 and V9 leads and reciprocal changes on V1 and V3. There is V7 is the elevation, 8 is the elevation, 9 is the elevation, and reciprocal changes in V1 is the depression, V1, V2, V3. On this slide you can see only reciprocal changes like is the depression in V1, V2, V3. No other changes in ECG. It is that we can manage this one like posterior basal myocardial infarction. Right ventricular infarction, isolated myocardial infarction is very rare. ST elevation in V1 leads. ST elevation in third leads more than 2 leads because third lead is more near to the right than secondly. ST elevation occurs mainly in VR3, VR6 leads. In addition, ST elevation is V1 more than V2. ST elevation in V1 plus ST depression in V2 is highly specific for right ventricular myocardial infarction. This ECG shows a full set of right-sided leads V3R, V6R, with V1 and V2 in their original position. Right ventricular infarction is diagnosed based on the following findings. There is an inferior ST elevation myocardial infarction with the ST elevation in the leads 2, in the third more than a lead 2. V1 is electrical, while V2 is significantly depressed. There is ST elevation through the right-sided leads V3R and V6R, you can see. Pericarditis is another disease with chest pain, sharp precardial pain, deep and diffuse, worse in supine position, relieved while leaning forward, aggravated during inspiration cough. History of viral infection, myocardial infarction. In this slide, you can see ECG changes in pericarditis. Widespread concave ST elevation and PR depression throughout most of the limb leads, first, second, third, AVL and AVF, PR depression and ST elevation, and precardial leads, V2 to V6. Reciprocal ST depression and PR elevation in with AVR. You can see PR elevation and ST depression in AVR. Sinus tachycardia is also common in acute pericarditis due to pain and for pericardial effusion. There is ST elevation and PR depression in the first, second, third, AVL and AVF leads, and reciprocal changes like PR elevation and ST depression in AVR leads. ST elevation and PR depression in first, second, third, and AVF leads, and reciprocal changes in AVR. ST elevation and PR depression in the first, you can see ST depression and ST elevation, second, and AVL also you can see is the PR depression and ST elevation, and reciprocal changes in AVR leads. This is myocarditis. Myocarditis changes in ECG. Sinus tachycardia with non-specific ST segment changes. Myopericarditis, widespread concave ST elevation, pericarditis changes in child with viral myocarditis. You can see ST elevation. This in the second, third, leads and PR depression in these leads also. Asymmetric hypertrophic cardiomyopathy. This is such this changes left ventricular hypertrophy results in increased precardial voltage and non-specific ST segment and T waves abnormalities. Asymmetrical septal hypertrophy produced deep, narrow, digger-like Q waves in the lateral V5, V6, the first AVL and inferior, the second, third AVF leads. This may mimic prior myocardial infarction. Like you see these deep Q waves in these leads. Apical hypertrophic cardiomyopathy. There is a localized hypertrophy of left ventricle apex causing a spade-shaped configuration of the left ventricular cavity on ventriculography. The classic ECG findings in apical hypertrophic cardiomyopathy is gigant T waves inversion in the precardial leads. It is a gigant T wave inversion in these leads you can see. This is the approach to the patient with ischemic pain in the chest. Because in the first, you can urgent assessment of the situation during the 10 minutes and provision of first aid. Urgent assessment of the situation during the 10 minutes. It is a determination of vital signs, measurement of BP with automatic or standard cough, respiration and pulse count, determine the degree of oxygen saturation of the blood, organize intravenous manipulation, IV catheters, set up an ECG or monitor in 12 leads, collect a brief, purposeful medical history, physical examination. The purpose is to determine the indication and contraindication for fibrinolytic therapy, determination of primary heart markers in blood serum, determination of electrolytes and initial level of coagulation. Require a portable X-ray. Observe less than 30 minutes. Provision of first aid. Oxygen supplies 4 liters per minute. Oral aspirin 325 mg to be swallowed after chewing. Sublingual tablets or spray of nitroglycerin, IV morphine injection if not relieved pain with nitroglycerin. Keep in memory MONA, morphine, oxygen, nitroglycerin, and aspirin. ECG assessment in 12 leads. There are three types of changes can be observed. First is ST segment elevation. The second is ST segment depression or inversion of the T waves in dynamics, and undiagnosed ECG. ST segment elevation, newly observed or suspected left bundle branch block. This always raises suspicion of myocardial damage. Myocardial infection with the elevation of the ST segment. Management. You can give IV beta blockers, IV nitroglycerin, IV heparin, angiotensin-converted enzymes inhibitors like captopril after 6 hours or when the condition stabilizes. Use fibrinolytic with a less than 6 hours after onset of symptoms. If fibrinolytic therapy is chosen, more effective are alteplase or streptokinase, retaplase, tenecteplase. Within less than 12 hours after onset of symptoms, choose a reperfusion strategy appropriate to local resource. Angiography, percutaneous intervention like angioplasty or stent. Reserve cardiothoracic surgery if there is a sign of cardiogenic shock or fibrinolytic therapy is contraindicated. Percutaneous intervention is a first choice class 1, if possible. If a percutaneous intervention is not possible, use fibrinolytic unless contraindicated. The second is ST-segment depression or inversion of T-wave in dynamics. There are very suspicion for myocardial ischemia, like unstable angina, risk of the myocardial infarction without ST-segment elevation. Management. According to the indication, the perfusion cannot be postponed. You can give heparin, aspirin 325 mg per shaving, IV nitroglycerin, and beta blockers. Evaluate clinical status more than 12 hours after the onset of symptoms. Patient is at high risk if symptoms persist, ischemia is noted, left ventricular function decreased, widened wave on the ECG, history of myocardial infarction, previously held myocardial infarction, PCA, and coronary artery bypass grafting. If the patient is at high risk of cardiac catheterization, should be performed. There are maybe two cases: suitable for revascularization or not suitable for revascularization. If the patient is suitable for revascularization, you can manage PCA, percutaneous intervention, and coronary artery bypass grafting. If the patient is not suitable for revascularization or patient is stable, you can admit to ICU, bed monitor, continue treatment according to the instruction of series of heart markers, ECG series every 6 hours, echocardiography or radionuclide examination. Undiagnosed ECG, evaluation of the patient, series of heart markers, ECG series every 6 hours, echocardiography or radionuclide examination. There are two situations: moderate to lower risk of unstable angina. There are no changes in the segment and T wave. If there are moderate to low risk of unstable angina, you can give heparin, aspirin 325 mg, IV nitroglycerin, and beta blockers. If there is no changes in the segment and T wave or in heart markers, perform hospitalization. Heart marker series include troponin, repeat ECG, continuous monitoring of the segment, echocardiography or radionuclide examination. There are maybe two cases. There is a sign of ischemia or heart attack. Evaluate the patient like in situation 2. Second, segment depression or inversion of T waves in dynamics. The second is no sign of ischemia or heart attack. Discharge the patient under the physician observation. Complications is a cardiac arrest in the chest pain. These possible factors: 6 age, and 5 teeth cardiac arrest. Hypovolemia, hypoxia, hypothermia, hypoglycemia, or hyperkalemia, hydrogen ion acidosis. Toxins, trauma, thrombosis. This can be coronary thrombosis, pulmonary thrombosis, and tension pneumothorax. Thank you for attention.